Yeah, I think it is. To be honest, the biggest issue that we had is I assisted on a couple of um, when I was still doing my student teaching, I assisted on a couple of specialty courses for the foot and the ankle, and they wanted us to break up the anterior and posterior joint mechanics, glides, treatments, all of those sort of things into separate entities, almost like we had a purely anterior subtalar joint and then we had a posterior subtalar joint. Um, it was so poorly received, basically, by everybody we tried to teach that to in that manner. Um, that we just went back to the way that Fred used to do it back in the day, is we just did it all as one joint, which in reality is the way the joint functions. The joint's not going to function independently as an anterior joint and a posterior joint. Um, Meaning you're not going to have just the anterior joint moving at any time. It's going to be the anterior and posterior joint. The difficulty with it is that they have alternating um, convexity, concavity alignments, right? The anterior portion of the calcaneus is concave, and the posterior portion of the calcaneus is convex. So they're going to have alternating mechanics when we look at how these things are supposed to move. The other thing that comes along with that is it tends to change the joint axis from being in a straight sagittal plane to it's actually offset slightly. So if this is my right foot here, if I turn my foot outward about 30, 35 degrees, something like that, that would make the axis of the subtalar joint in a straight sagittal plane. So that's also a component of having these two separate joint compartments that are associated with this sort of thing. So the idea here is it's more of a torsional moment, almost a pivoting type of moment, where we get the anterior portion. So if this is the front of my calcaneus, if we get the anterior portion to swing laterally, the posterior portion here is going to swing medially. That would essentially be an eversion moment, right? Because we're naming it based off where the front of the calcaneus moves. If it moves laterally, that's going to be eversion. If it moves medially, that's going to be inversion. What you have to understand is the only thing you really have to understand here from a mechanics standpoint is if the front anterior compartment goes laterally, posterior compartment is going to come medially. That's going to be eversion. If we reverse that, anterior compartment swings medially and the posterior compartment swings laterally, that's going to be inversion. It's really as simple as I think as I can make it. We will spend quite a bit of time on it in the actual lab, but that's the biggest two things is looking at this as one joint versus two separate joints. I really think from a functional perspective, it's the only way we should be looking at it, because we're not getting individualized anterior versus posterior subtalar moments. They move together, but they have alternating mechanics because of the change in joint shape. Does that answer questions here? Was it Kevin that I was asking that?
Yeah, that helps. Thanks, Eric. I think
Sure thing.
part of the confusion lies in the nomenclature and how we named it. I think of like a calcaneal eversion. If I'm looking from the posterior aspect of the patient, I see kind of that valgus moment at the heel, and I would call that eversion, right? And so I think that's where the confusion lies. So yes, that helps. Thank you.
Sure. You also have to consider that it will look slightly different in weight bearing versus non-weight bearing. So if you're looking at the back of somebody's heel and it swings inward, right? It's not the joint surface that's actually swinging inward. It's the apex, the bottom portion of the heel that swings inward with subtalar inversion, right? So if somebody goes up on their toes, the heels should kind of squint in at each other like this. It's actually the bottom portion, the apex of the heel that's moving inward, that's associated with inversion. But if you're looking at where the actual joint is, because the bottom portion of the heel here, the joint's way up here. This is actually going outward like that. So some of those sort of things may be a little more complicated based on weight bearing versus non-weight bearing as well. And again, we'll do differentiation based on weight bearing versus non-weight bearing mobility tests during the course as well. We have some functional tests that we do both those things with.
Yeah, I've hidden here. I'll share my screen. I'll pull up a quick video just demoing. Again, it's different terminology, how these things are used, but just take a quick peek at it to see if this. I was trying to find one that had a good bone description of it, so I think this is one of the better. Let me know if the sound doesn't work.
Hmm.
And the sound doesn't.
I'm not seeing much of anything. Nope. There it is.
Just kind of shows, the subtalar joint glides. The next one I'll play would be more of an animation. So you see eversion, inversion, really kind of giving a better representation of what you may see the posterior joint from the view. And you can kind of get a sense of that representation of the convex motion of the calcaneal portion. I think it's a little better sometimes appreciated from looking at it from the action of the talus on the calcaneus.
Yeah. Well, and you can see kind of what I was talking about there at the very top where we get that convexity, how much distance there is to the apex of the heel, the bottom of the heel there. So in reality, what should happen is we should get the apex to go medially like that, where the convexity here at the joint line to go medially, whereas the actual apex of the heel goes laterally. So it should be pivoting like this, as opposed to doing kind of this straight glide like that.
Mm-hmm. See anything else here? More animation in here. And here you get a sense of the talus motion. Calcaneus is certainly moving with the talus motion there on the calcaneus. And it's nice because you get a representation too of what's happening at the other bones of the foot. Now it's all different things, and no diagram like this is going to be perfect in its representation. But you get a sense of what does that talar motion look like moving into, be part of that pronation. And it elevates down and off of it. They often talk too about sometimes like the talus, if you're like an Archimedes screw is an ancient screw they used to move water uphill, the way the screw was shaped. And that this joint kind of functions when you watch it go into resupination by the shape of the joints, it twists it. You can see the elevation of the talus as it comes back up as it goes down. They need to describe it many times like an Archimedes screw by the shape of the joint. As the talus rides back up, it elevates the talus. Kind of in my mind, the mental picture, if I think about, okay, what am I seeing? What is the talus doing as it moves? That's kind of pretty close to what I like to keep in my mind.
Yeah, and you can see the anterior translation of the talus over the calcaneus in that animation there.
Mm-hmm.
And it's basically as the heel hits the ground from a functional perspective, heel hits the ground, the calcaneus comes to a stop, right? Funk hits the ground, it stops. The talus then will slide over the top of that, and that'll drag everything into that eversion pronation sort of moment, right? So the calcaneus will be everting, the rest of the foot will be producing a pronation moment.
Yeah, that animation's good. Thanks, Dave.
Yeah, I'll see if I can find more of them to kick out. And that's just kind of like where I think in my mind. That's the mental picture when I need it to be the easiest. That's what I want to see in my mind. It's like, this is what's going on. And many times as PTs, what we're looking at is, here's pronation, supination, but it can often, what comes down for us is the rate at which it happens becomes the problem. It's the force, momentum, how well it's controlled. Those are the things that are stressors when we're looking at runners and people walk and slow breakdown. So understanding the mechanic and what goes on in space is the first thing. Then two, then it's about how fast do those motions happen, how much stress is placed on the system, and can I pull out of it at appropriate timing. So timing with orthotics is kind of one of the key issues. If you look at quick foot is how quickly are you moving in and out of each appropriate phase. And the article that was out this week was on basically just central peripheral sensitization. I thought it was a good one to kind of set up what we'll probably do next week, where I had more in there where we'll talk about segmental facilitation, ectoplasmic flow. We'll get into some of those other variables that are less well described side of some of the classic osteopathic literature that was there. But I thought it was kind of important to kind of include this and follow with the next one, so you kind of get a whole picture of kind of what's current in literature. How does this play in? What are we doing? But then also thinking about just treatment planning as far as this being a component and what we may see. Here real quick, just a real quick view again of the carpal bones that we had the last time. Getting a sense of the lay of the wrist. We know we kind of clearly delineates the proximal row, scaphoid, lunate, and triquetrum. Again, the distal row with hamate, capitate. Got trapezium and trapezoid in that row. So just getting a sense of where we are in space, because part of what we'll get into is we have the carpal tunnel coming through these. And one of the things that you can do is, if you're looking at some of the techniques that you've seen in the past, your soft tissue techniques, for those of you who do ASTIM or Graston there, but also understanding the ligament where the median nerve may be getting entrapped. We'll talk at the end about, okay, carpal bone mobilization. I mean, somebody has median nerve entrapment or you're having symptoms down here. One of the things that you're going to end up doing after the course and you're going to want to know is, what's the relative mobility of the wrist? What are these contributing factors? In part of my treatment, it may be that, okay, maybe I don't have subluxation, but if I know where the transverse carpal ligament attaches and I can do my mobilization, you can work in the wrist with a little bit more specificity, I think. Just understanding the bones, the soft tissue ligament attachments, and just getting a sense of the neural involvement. Kevin, since you're up to bat here, in your mind, when you think of peripheral sensitization, what do you think of?
I think of a localized issue. I'm either probably seeing some soft tissue dysfunction or sensitivity, tenderness to palpation, maybe soft tissue pain if I stress it, either contracting or stretching it, and then maybe just some we'll say kind of hyper responses to stimulus that wouldn't normally be painful or aggravating.
Yeah, we're going to talk about the carpal tunnel. What other area of the body, if you think like you see a bit more peripheral sensitization, have you seen it? Does anything come to mind?
I think a lateral elbow pain. I recently had a patient came to me primary complaint of shoulder pain and stiffness, and he really presented almost like a middle-aged female with like just a stiff shoulder, but it didn't really follow a capsular pattern. I keep following it along. I asked him about neck pain. I assessed the neck, and he would not let me take him to the right. So traditional like stress testing, he wouldn't even let me do. All my nerve glides, like my nerve assessment was negative. Neural tension tests were negative. So I start working my way down into the elbow and the wrist. So at that point, I'm trying to differentiate between a C6 issue or a median nerve issue. And so I started investigating carpal tunnel. And some of it's positive, some of it's not. One of my differentiators between that and like a median nerve issue, peripheral issue at the elbow is I'll test flexor pulsus longus because that innervation is proximal, and he tested weak there. So then I'm thinking, well, maybe he's got an issue at the elbow. And then it just got so muddy that like everything was lighting him up. And it got pretty frustrating. It was just basically his whole right upper extremity was a muddied mess, and it was difficult to figure out. And so this article made a lot of sense to me this morning. I was reading through it, maybe some of what's going on with him, because all of it kind of presents together.
Yeah, I mean, these pages are going to be somewhat of a hodgepodge of things. That's what the article kind of also alluded to. In some ways, some articles help you think, man, I can use that, and somebody can help in treatment. Sometimes I find articles liberating and going, yeah, that's what I see, and it is as muddy as I see it. And I'm glad somebody finally wrote it down for me to read. So that can be helpful as well sometimes in saying this. But, peripheral sensitization, we can expand on it. The definition from the article is basically we're looking at increased responsiveness to reduce threshold of peripheral nociceptors. There can be also field expansion beyond the typical field where there's a bit of collateralization that occurs. And now all of a sudden you have an enlarged receptive field that becomes hypersensitive to stimulus. And again, here they're also talking about, endogenous, allergenic substances and neurogenic inflammation. So inflammation releases substance P, histamine, prostaglandin, all those types of chemical, mediated stews that irritate nerves will also kind of contribute to peripheral sensitization. Abby, what do you think about when you think about central sensitization?
I think about, I don't know, like the whole, it's been a day. Central
It's okay.
sensitization. I feel
Your
like
words.
it's more like a whole distribution of the nerve. It's not, it could be like what the article was saying, that even with the peripheral, it was like the whole hand and like the extra median and all that stuff. But usually it's like a whole dermatomal pattern and myotomal pattern for the most part.
Central sensitization gets a little crazy because with central sensitization, it's really happening. You think about this in certain areas as we modulate pain in the central nervous system. So, here, we're going to go back over the pain chart, which we really started this program with, you know, to where all of a sudden you could have it, maybe it's at the dorsal root ganglia, maybe it's the spinal cord level, the PAG and midbrain. And also, within the cortical map itself, which could be the interaction of, 30 to 50 areas of the brain that now coordinate what we're feeling, what we're doing, where sensation's coming from. That central sensitization, once you get in there, gets into that bit of that, I won't quite call it a black box, but of the central nervous system, how that central nervous system responds, to what's happening in the peripheral nervous system. And and the last thing they called in this article too was the increased responsiveness due to dysfunction in the endogenous pain control system. And it's good that it brings it up here because it's a nice time to review it. And remember, on Friday I bored everyone with this big long image of what is the endogenous pain modulatory system. And we did this because, when we look at manual therapy, we are really looking many times at we're focusing in on this the biomechanical evaluation and treatment of people, including manipulation. But within the world of manual therapy and a lot of what we do, it's also managing this central pain endogenous system that goes on. So, when we manipulate somebody, when we dry needle somebody, if you A-stim them, you know, in some ways, what we're hoping to do is to interact in the central nervous system through one of these mediated pathways at the peripheral system, at the spinal cord system, where they talk here about, neuromuscular responses, neuromotor motor pull, afferent discharge, muscle activity, hypoalgesia. Those are all things, or hyperalgesia in this case, if we're getting central sensitization. So, like, we look at the diagram, and this is for pain modulation, but you can take the hypos and turn them into hypers. And this is also kind of where the central system gets upregulated. And brain circuitry one is one that now has been expounded on, where they talk about in this article about how they looked at, the motor areas and some of the cortex was getting blurred between the different fingers in the hand. And these people had spillover of symptoms into distributions that were outside of the median nerve. And one of the explanations for that with this case was that, okay, these people with, carpal tunnel syndrome have some of these centrally mediated responses, just you see this larger area distribution occur. And that's one of the signs they look at and saying, hey, here's somebody who's presenting like carpal tunnel, they have a lot of symptoms, but there's a large degree of spillover into these other areas. And they're attributing that to some of the central sensitization that occurs. It's a nice reminder real quick of like when we're operating in these systems, yeah, we want the mechanical effect of, okay, I'm improving this joint's ability to move. But many times what we're also doing is modulating my body's, system as far as how it endogenously manages pain. But also, sorry, I lost my notes there. How we're endogenously managing pain. But then also, what's my cortical map doing? What am I doing in my brain? It's processing process. How do I restore normal motion and mobility and movement patterns so that, we're not also kind of chronically, pressing dysfunctional tissue. And that was another area they addressed in the article, that altered brain map and motor coordination pathway, seeing overflow into the opposite arm even, saying that okay, coordination deficits in the unaffected limb is due to some of these centrally mediated processes. Eric, any thoughts on this kind of more global picture of central sensitization, peripheral sensitization?
Yeah, I mean, I could go into a lot of stuff with this. Essentially, when we're looking at this sort of stuff, we're looking at some sort of, it depends on who you talk to. Jim would say it's going to be nociceptive problems. Some other people might tell you that it's only going to be abnormal sensory feedback, whether that's nociceptive or not. You know, honestly, I don't know that I have a hard answer on either of those things that sets
Yeah.
off these sort of problems. Um, Jim's argument is that nociception doesn't always have to produce pain. You know, it has to hit a certain threshold before it would do that. Okay, fine. You know, I think it ends up being kind of a relatively similar thought process if you're looking at it from that perspective. But essentially, if you look at it from these abnormal feedback loops, right, some sort of sensory input is getting looped into this system, and it's not what the body is typically expecting. This creates a summative effect, right? So it starts to accumulate in this pool of interneurons within the spinal cord, right? So as we're looping through that dorsal root, and it's kind of going through the reflex arc and whatnot, and it's kind of starting to spit out these additional signals through the motor system, and through some of these reactionary systems that we have, which can be sympathetic, which could be motor, which could be neuromuscular, any of these sort of things, start to get ramped up because these reflex mechanisms within the spinal cord are starting to get, their threshold is starting to slowly lower, right? So if we have a threshold and we need to depolarize, we need to hit that before we get a response, it's starting to lower that threshold. And so essentially what happens is we start to get these increases in these external responses. And you know, there's a lot of different thoughts on what would cause that sort of stuff. There's a lot of different thoughts on how to change these things. The way it was always described to me is there's kind of two stages to it. There's an electrical version of this sort of problem where it's relatively new, and all we're getting is this increased conduction going through these systems. So again, kind of winds these things up, but it's a reversible, fully reversible problem, where if we can decrease that electrical output, we can actually improve this thing over the long term. There's some thoughts that suggest that if this electrical output is or input and output continues to be processed through this system, through these pathways, that eventually there's a chemical change at the synapses. And essentially this means that there's always a higher resting amount of neurotransmitter, and it's essentially always depolarizing and crossing these synapses. So it becomes problematic at a more chemical level, a more molecular level at that point, and it's impossible to fully reverse those things. There's been some speculation, and we'll talk about this when we get into like module 7, that's part of the way that chronic pain syndromes like fibromyalgia become more prominent. Is we have these facilitatory and central excitation problems that essentially become more global. They start to spill over into all these other areas of the body, but they start to develop at this more chemical level. And once that sort of thing happens, there's no fully reversing it. And it's almost like a drain. It'll kind of spiral into that sort of stuff and continue to progressively get worse at that stage, because essentially whatever the stress was, whatever the problem was, it starts to kind of facilitate that pathway. It never gets broken. So yeah, like I said, we can go into this stuff all day long. There's a lot of theory here, some actual evidence that will support some of these things, but you know, realistically, our job when it comes to manual therapy is we have to find out what the stressors are that instigate these particular problems, right? So if we're looking at it from a peripheral perspective, we got to figure out what's causing these problems in the periphery. You know, is it an adaptive hypermobility? Is it a, you know, mild to moderate compression of a nerve? You know, is it an old trauma? Whatever we end up finding there. If it's more central, so if it's in the spinal column, we're typically going to be looking at some sort of adaptive hypermobility, something that's starting to break down, and it's creating these abnormal sensory feedback loops that continue to wind things up. And again, it should be like Abby was saying, it should be more segmental if it's coming from the spinal segment versus peripheral. Now, Jim, I think, would give you the argument that you can have central sensitization from a peripheral structure based on its segmental innervation. I think that's hard to. Personally, I would think that that's going to be difficult to prove because of Hilton's law, the idea that, okay, if we have a joint that's irritable, say it's your elbow, for instance, joints swollen, joints irritable, it's just kind of beat up over time here. From a segmental perspective, basically every segment that crosses that joint from a muscular standpoint, everything down from C5 through C7, C8, even if we're starting to look at some of the muscles that cross into the wrist, would also be wound up as a result of that. So you're not going to have a specific segmental irritation from that. So I think the idea of the segmental to central stuff is going to be coming more from the spinal segments, which tends to make sense. And the peripheral stuff is going to be more consistent with what we were just talking about, what if it's directly there at the elbow or any of the peripheral joints. So it's interesting stuff. And like I said, we'll get into it a lot more as we push forward with this sort of thing. But again, a lot of this is there's not a lot of strict evidence to support most of this sort of stuff. In fact, I think if you talk to a lot of physicians, Dave, you've probably had this issue as well, a lot of medical personnel, if you start talking to them about segmental facilitations and central sensitizations, they kind of start to turn their nose up at you a little bit and start to doubt whether or not it's a real entity or not. I'll tell you, I see it all day, every single day in the clinic. So I'm completely sold that this is a real thing. And it's one of those things I think that really tied physical therapy together for me as a orthopedic therapist, because it's just like occasionally you see these problems and you just don't have any clue where they're coming from because they seem kind of scattered. They're coming from all these different areas. There's no real ways to, it might even kind of seems similar to what Kevin was talking about earlier. It seems like these things just don't match up with any one thing. And these two things, these sensitization problems, they kind of really link those things together for me. If you can start to understand that, then you can kind of put these things together, even on patients that have, kind of these unusual presentations.
Yeah, it's, again, yeah, I've had courts rejected for approval in one state because I mentioned central sensitization and I'm saying there wasn't enough evidence to support this and it's unfounded. Or not central sensitization, but segmental facilitation. Because basically they rejected it. They wanted to blast segmental facilitation. But like Eric said, I see too much of it and I can impact too much of it for it not to be there living within this. But that's kind of why I wanted to do this, like talking about it next time. I figured, okay, let's go over peripheral and central sensitization, how it relates in our world here. So we understand this. So when we go to the next layer, you can kind of differentiate between them a bit. Okay, see where there's probably some overlap, where they exist together. There's probably also some differentiation points where you won't always see one with the other.
Yeah. And I would tend to, I think we talked about this on the last module when I was there, guys, and just a little bit because it was module 3, but the idea of peripheral sensitization to me tends to lend more to the idea of axoplasmic flow problems, right? So we're dealing with some compression, tension, traction, something that's affecting the flow of nutrients and microtubules and all these different things that go through the actual axons of the various nerves. What that tends to affect is it tends to produce more of a fatigable weakness when that sort of thing is present. Central sensitization lines up much more with the theory of segmental facilitation, and that's going to wind things up. It's going to increase tone. It's going to increase sensitivity, all these different things. So everything kind of goes up. So we shouldn't see these two things being confused too often, because the reactions, the things that we can test, strength, sensation, reflexes, things like that, they should go in different directions. At least that's the way that I tend to look at this sort of stuff. I don't know if you have any other, Dave, if you have different views on that sort of stuff.
I mean, I agree. It's different the way you test it and kind of the way you look at it. Like, I may see that somebody's like, okay, there's a component of sensitization here that exists within them, but I'm not seeing, segmental facilitation. I'm seeing segmental facilitation often, without a large degree of a sensitization component. So, no, I mean, most of the people I see when I'm finding this, I will find the segmental facilitation almost incidentally. They're coming in for a tendinopathy or some other problem or something broke down during a movement, and then I come into that. So they're not often as sensitized as this. Can be a little bit muddier because of the overlap, and there could be some overlap, but sometimes you clearly delineate between the two.
Yeah, it's an interesting thought because what you just said is that the idea that you usually find these things secondarily when looking at some other problem. It's part of the reason that I think strength testing, or I call it force
Yes.
output testing, because we're not testing just purely for strength. We're testing for recruitment, we're testing for palsy, these different things. So force output testing, I think, becomes one of the most important things that we can do as manual therapists, because I know we talked about this, where we look at, the different types of weakness that start to pop up, right? So that breaking weakness that comes more with either pain inhibition or reflex inhibition, which tend to indicate either local tissue damage with pain inhibition or local articular or soft tissue pathology with reflex inhibition, versus something like a fatigable weakness where it's going to get weaker as we go, is going to suggest more neurological involvement, right? So radiculopathy, peripheral neuropathy, or axoplasmic flow issues. Those things are going to show up as these tests that we do. They're going to get weaker the more we test them. So if we repetitively test these things, they're going to show up as weaker and weaker as we go. Facilitatory effects, things like a segmental facilitation, it's actually going to be much more velocity dependent. Now, I don't know if Jim really buys into this whole process, but I see it every single day in the clinic, where I can test somebody at a nice even pace, put my hand onto something, see if I can get some weakness to pop up, and I get nothing. If I start putting that pressure on that system much faster, the weakness pops up just like that, and it's immediate and it's consistent in how it reacts. So it's definitely something that I see from a clinical perspective, whether we have evidence to suggest this sort of thing, meaning we have some sort of gold standard test, imaging, conduction studies, all these sort of things that you would look at to say, okay, yeah, this definitely suggests that there's some sort of issue here with the neural conduction pathway. That's not the way things operate in the clinic. In the clinic, you have to look at what shows up and the way you test things, and whether you're not able to affect these things via either your testing or your treatment. So once you kind of look at that stuff for enough years and you see it consistently enough, you kind of prove it to yourself that it really is there. And I can show you guys, I think we went through some of it a little bit briefly during module 3, but I can show you guys what I'm talking about as part of a review when we get there for this next module in a couple of weeks. But it is an interesting dichotomy that usually you find these sort of things as a relative thing and maybe a contributing factor, but not necessarily a causative factor to the patient's complaint when they come into the office. That's just kind of an aside, but at the same time, when you find these things, you can see why sometimes these things would become problematic. I always look at the example that I always used to give was back in the late 90s. I was a big baseball player growing up, played a lot, played through college and whatnot. And the guy that always confused me was Ken Griffey Jr. He switched teams, went to play for the Cincinnati Reds, and he was always hurt. He kept blowing out his hamstring, constantly had hamstring strains. Nobody could figure it out. He did rehab for months and months and months. They did all this work on him constantly. He'd come back 2-3 games in, hurt again immediately. There's a guy that plays for the Denver Broncos right now here in my hometown, has had, I think he's been on injured reserve 6 different times in 2 years with hamstring injuries constantly. Guy's doing nothing but rehabbing his hamstring. And it just keeps going out as soon as he gets back to practice, gets back to playing. When things like that start happening, you have to start suspecting that there's some other underlying causative factor here. To me, a segmental facilitation fits those problems to a T. They start running, they start cutting, they start jumping, they start making all these changes of directions and whatnot, high velocity movements. And all of a sudden, these tissues start breaking down. It's probably because that tissue is wound so tight that it's protecting some sort of neurologic structure, or it's facilitated to the point where the structure cannot lengthen at that velocity, and it keeps breaking down. So again, this is kind of that missing link type of thing when you find that sort of stuff, and you can kind of relate it back to things that people see in clinic in the real world, and how these sort of things happen. So again, we'll talk more about it. I don't want to, now that I've spent 15 minutes talking about it, or 10 minutes talking about it. But I don't want to, belabor the point here today, but these things are things that we have to be conscientious of, because patients going through typical rehab where they're just doing exercises trying to strengthen a muscle, they're not going to have too many issues until they get into these high speed activities where they have to trust their body, they have to trust the different structure is going to hold up, and it just won't. It probably can't, because it's continuing to hit these tension points that are just there only at these high speeds. So again, I won't go too much more into it at that point, but that's just something that I see a lot of, and something I think we have to be aware of as therapists.
Yeah, and that's where we're gonna kind of go between the two. That's where I thought the discussion would be good over time, these next few months, to be able to talk about that, because you have that velocity dependent weakness, and you can play that against if you look at the last point here under back to sensitization, which is, I'll send these notes out to you, is altered motor control patterns reflect the reorganization of the motor control strategies within the central nervous system, and sensory neuroplastic changes in the somatosensory cortex results in decreased fine motor control. So it's interesting when Eric talks about that. It's that interplay between, okay, is it this sometimes? Is it more segmental how we find it? Because this concept here in that last bullet point, it's been looked at here, certainly in the hand and motor coordination of the hand. Really where they look at this is they do transcranial stim and look at brain activity, and they've seen it with Achilles tendinopathies and ankle sprains, that this cortical remapping commonly occurs. And then it's, okay, how do you rehab some of these cortical maps, which now become aberrant based on the injury dysfunction, whether it's carpal tunnel syndrome, or in the lower extremity, we talk about Achilles tendinopathy, which is one that's been studied from there. If there's any other points in here worth talking about. Yeah, these other points are the ones we talked about here. If I go up one to where studies hypothesize, where they'll talk about, the long-lasting peripheral nociceptive stimuli originating from the median nerve could lead to, neuroplastic changes in the central nervous system. Also both the spinal cord and brainstem levels, which again goes back to that initial, busy diagram on the pain modulation and mechanisms of manual therapy. It also gets back into where else can these patterns of aberrant input come in. And if you understand is that, with manual therapy and what we're looking at with joint mobilizations, we'll get into treatments in just a bit of how we also can interplay in the system of peripheral or central sensitization, as well as segmental facilitation. Again, last one too, we'll go here is, they found that women with strictly unilateral carpal tunnel syndromes exhibited, widespread pressure pain sensitivity over, the radial ulnar median nerve, cervical spine, tibialis anterior, suggesting this widespread hypersensitivity to pain controls. So that with this chronic aberrant input, we're going to look other places. And again, our treatments, this person may be a carpal tunnel patient, but I can probably tell you, but Eric probably does similar to me. It's like, I want to get the lay of the land in this individual. How are they moving the entire upper extremity? What is going on in their neck CT junction in evaluation? I want to kind of get the whole picture of this individual, because what I want to do is I want to get lucky, find that, okay, I have multiple issues or multiple things contributing to the neural tension that is treatable. I have maybe a C6 or C7 lesion up in the upper neck that's contributing to this that I can treat, as well as maybe something going on within the carpal bones that could be restricted. We're going to kind of learn and go over that. So from a manual standpoint, I want to see, do I have these things? And from a neurophysiological standpoint, it's like, okay, well, maybe I don't have a mechanical subluxation, but working within these areas, if we're dealing with a sensitization process, is going to be beneficial. Proprioceptive input, through the carpal bones and mobilization. The joint glides that you probably saw in the videos are also kind of, as you go through them, are going to be your joint mobilizations to a degree as you go through the hand. All right, this individual, Let me think here. Chris, typical carpal tunnel patient you see. Yes.
Oh, with ours, we see a lot of worker. They work from a local meat packing plant, so we see a lot
Jeez.
of like wrist and shoulder, like repetitive
Uh-huh.
use, and same thing all day long. And usually they go first to see the doctor, and they'll give them like a wrist splint, some sort of brace of some sort, and some sort of steroid. And I don't know. It's a lot of it too is they're also looking down all day long. So I've started to look at the neck more now too,
Mhm.
to see if that has any role in it. Um, but yeah, I thought the article was really interesting because it talked about too how a lot of times with it doesn't necessarily always follow that median nerve pattern in the hand as well. Because I'll see that quite a bit where people say it's their entire hand that goes
Mhm.
numb or goes tingling. And so it just was interesting to see that as well.
Yeah. Interesting about these articles sometimes is just to see that other people are seeing things that you've seen that at times that haven't made sense. Where this
Yeah,
you can't have these overlaps, and it's like 88% in the one article, and I think in females that they looked at these
right.
overlapping distributions. But I
And I
can
thought
tell
it
you,
was interesting too with the
go ahead.
just with the 30% recurrence rate with carpal tunnel surgery as well, because it seems like there's a lot of patients that come in too where they're like, I had carpal tunnel surgery, why does it still hurt?
Hmm. Yeah, and that's where it's like, okay, now you're left with looking at some of these other things. Here, what I did is I put up some images just to kind of think about the first image you see here is okay. Here's Jim looking at basically probably scaphoid on I think trapezoid in this image. Think of the meatpacking patient that you saw, Chris. I mean, probably what do their hands feel like? I mean, I can get a mental picture of what this person's hand looks like or feels like to me. How would you describe their typical presentation?
Oh, I mean, usually like very stiff. I mean,
Yeah.
I've been going through a lot of the carpal bones now too, and just
Hmm.
wrist extensions all is always like nothing. Like
Hmm.
it's just it's easy to find deficits when it comes to wrist and carpal bones.
Yeah, I mean, what you're probably seeing is that folded hand. It's commonly what I'll see is the hand prefers this
Yeah.
position. That ability to open and splay through there is difficult. And they're thickened through probably the transverse carpal ligament and the fascia through the hand. Somebody's working at a meatpacking plant. Because I imagine what they're doing is gripping. Big deal.
Yes. Yep. Yep.
And then what you probably find is that if you look at the proximal row, probably have a scaphoid and your scaphoid lunate or your trapal and trap mobilizations are probably fairly limited, stiff.
Yes. Yep.
Anyone else seeing a lot of carpal tunnel patients or any carpal tunnel patients? Teresa, we haven't talked in a while. What's going on? Carpal tunnel?
Hi, Dave. I have an OT in my clinic, so to
Oh,
be quite honest, I
oh,
defer all of this to her.
geez.
So you're gonna come take your
Yeah,
exam
I
for you?
mean,
Yeah, you gotta bring her
no,
along.
they're not, Eric, which is why I'm closely paying attention and learning, but I don't have as much hands-on experience in this department. Honestly, every clinic I've ever been at, I've had an OT. So I personally, the only experience I get is when someone comes in for direct access, because just next week is that only now available for OTs in Illinois. So typically if someone's coming in with an elbow pain, direct
Uh-huh.
access, that's when I'll see them, but it's few and far between.
Okay. Well, you're no help.
No, I'm not, but I'm kicking back and absorbing as much as I can.
Okay. I'm not gonna ask Chan. Chan's probably got a dozen of them, don't you?
We got a whole hand therapy staff, and so this is interesting to me as far as to go back and to talk to some of the therapists about that. We got a couple of certified hand therapists that are pretty territorial regarding hand stuff, but I got a couple of other OTs that are always up for learning something new. So to me, it's a
Mhm. Yeah.
share.
These we could look. I mean, commonly what you'll see, there's some tendencies too that they see. And people with thicker, there's a wrist index you can measure, and people with thicker wrists, broader wrists are more common to have carpal tunnel. But the reason I lay these images up here first, because you think of from a manual therapy world, it's like, okay, we talked about sensitization. What can we do? Understanding the carpal joints and mobilizing them. There's going to be some benefit there, especially if they're restricted or subluxed, then absolutely. If you can restore some of that motion, like Chris's patients, he finds something that's restricted in the wrist and he frees it up. Again, if you get lucky, then is that a primary stressor or is that just a secondary finding? So you don't know, but I know within here, one of the key things I want to do is if I can improve, if I have restricted carpal row mobility, can I improve it to any degree? I mean, you're trying to do that with your ASTIM techniques in a sense, if you're looking at, collagen information and breaking it up. But getting a better carpal mobility or glides in here, maybe especially if you have a a scaphoid, which is more I guess internally rotated than that carpal position, that gripping position, or that folding position of the hand. You want to kind of take a peek at those things. Certainly anything in the elbow. Next one thing, but it's the cervical spine. They're talking about okay, these individuals having it there, and the cervical spine is a strong place for basically sensory integration or innervation. So find something in the cervical spine. Is there anything there? Jim will talk about he may not necessarily go up there right away because you don't want to create problems or they don't have problems. And I agree to it to an extent, but working up in here and treating the sum of the whole person has great value, especially when we go back to that initial diagram of mechanisms of manual therapy and their intervention is that, me mobilizing, working gently through the neck and just doing the joint glides of the oncovertebral joints or the facet joints, within there, I have this pain modulatory component. Or if I want to treat central sensitization, gives me a way to get in there and treat the central nervous system. So this person may have carpal tunnel and it may be compression, but this would help me treat some of that underlining sensitization that also may be occurring. And if you have a double crush syndrome, or this area where the nerve is restricted in multiple spots, then it's something I go through. Free. So being up in the neck in this individual at some point is probably going to be beneficial, if for nothing else, just to kind of be able to evaluate the patient's response, to that intervention. Eric, any thoughts on how often you're in the neck with these carpal tunnel patients?
Yeah, I mean, I think that the thing that I always look at, if I have somebody with, what I would consider peripheralized symptoms, so something into the arm, hand, wrist, etc., and I'm suspicious that the neck or the CT junction or even stuff under the subclavicular space, things like that are contributing. The first thing that I'm going to do is I'm going to get a baseline of their upper limb tension tests. So looking at mostly median and radial, they tend to be the ones that are most consistently affected with these sort of things. But it would tend to suggest if I have more than one positive, meaning either I have a loss of excursion in an upper limb tension test, because in theory, I should be able to take this thing and get it all the way out there, completely elbow extended, wrist extended, shoulder depressed, all these sort of things. I should be able to get to all of those ranges without any type of restriction. Because if you think about it, this is a functional position for the body to be in, reaching for something, grabbing for something, any of those sort of motions. And if I have a limitation of motion because I have nerve tension, that's not a good thing, right? Because what's likely to happen? You could potentially damage part of the nervous system because of that limitation, right? So same thing with a radial nerve position. So if I have a limitation of motion or reproduction of symptoms, either one of those two things, I would consider that a positive. I will go through and I know Jim says, well, we don't want to necessarily get too far away from the location of pain early on, because we don't want to start causing additional problems in other areas that we didn't previously have them. So if we have somebody coming in with carpal tunnel issues, we'd certainly want to look at the wrist. But we can go through, and if we find something mechanical, we can fix that, and then we would go back and retest. And so essentially, if I fix something at the wrists, fix something at the elbow, but I still have a limitation of excursion on those limb tension tests, right there, I know that there's still something creating tension, and I'm going to have to keep going up the chain. So I'm going to be looking at the collarbone. I'm going to be looking at the CT junction. I'm going to probably look at the cervical spine. As far as the cervical spine individually goes, we could do something very simple. We put them in a tension position, essentially get to the point where whatever the limitation is, and then we alter the position of the head. So if I move my head away from it, it should get worse. If I move my head toward it, it should get better. If there's a cervical spine involvement with it, right? So there's a couple of things that you can do there. But that to me, and again, I tend to go through this stuff in much more depth when we get into, I think it's module 6, when we do more shoulder girdle based stuff, discussing how we use this, because essentially if I have a situation where I'm experiencing peripheralized, just having a patient that is experiencing peripheralized symptoms into the limb, I want to look at the other areas that could potentially cause this. So I'll look at the wrist, I'll look at the elbow, kind of work my way up. And the area that I treat that then provides me with the most improvement on the excursion or symptom reproduction for those upper limb tension tests would be the area that I'm going to end up focusing on my rehab components, their home exercise program, the things that they're going to do from a movement reeducation perspective in the clinic, all that sort of stuff. It gives me a much more zeroed in pinpoint place to go and work on that's going to give them the most bang for their buck when they leave my clinic, right? So when they go home trying to take care of this on their own. So I think that's a good way to kind of not just differentiate where problems potentially are coming from, but also give us a better priority as far as what we want to use for those home exercise programs, those re-education programs, things like that, as they move forward in their treatment. That's the way I do it anyway.
It's kind of here, I just put some hot, some cliff notes here. That's what they are. There you see, like, the neural gliding tensions. It's like there's value in looking at those things that Eric just talked about, understanding like, what's the nervous system doing, what's the sensitization. And again, I just put in PNF exercises as one example of a movement-based intervention. That's the entire limb. So if you are looking at somebody who is doing a bit of sensitization, you often find that, bigger, gross, big movements taking almost there. So if you look at some of these things, like, yeah, these are kind of exactly like the neural glide positions, which are taking the shoulder and the wrist and the forearm through large ranges of motion. So if this is somebody who does have some type of sensitization, and there's value in looking at more global movements versus just fine hand movements, which probably give them symptoms. That may be even one that for Chris, you may find that, okay, that it's not going to be your entire treatment, but a bucket of your treatment may do well, incorporating looking at shoulder, elbow, wrist, thoracic motions, or even incorporating neck in there as well.
Well, and I think this is part of the way that, even folks that are in work situations like Teresa or Chen, where they're like, hey, I have hand therapists, I've got OTs, I don't get to see this stuff very much. It's just like, well, you know what, if you go to those therapists and those hand specialists and you kind of let them know about these sort of things, saying there can be contributions coming from up higher, kind of work these tests in there, or at least take a look at them. Or if you have those patients that are like 80% better after they're working on their hand, wrist, elbow, etc., but they're not getting over the hump, they're not completely back to where they'd want to be. That's how you can kind of get yourself involved in these sort of things, because the odds are that the other contributing factors are up the chain somewhere, which would be someplace that's more in your guys' wheelhouse. And so you can kind of get your feet wet with that sort of stuff in that sort of regard, because you can go in and do this stuff, but then as you're going in and testing these things, you can also look at the mechanics down at the wrist and the hand, just as an aside, because there's probably mechanical things that you'll be capable of doing and aware of, that even certified hand specialists and OTs won't know about. So that's some other way that you guys can kind of get your hands in the pot, so to speak, here, so that you can actually see these things in clinic as well a little bit.
Yeah, as you go through a collaborative model, you go to collaborate with them and say, hey, listen, I was doing this course. Here's some things we took away from, I'd be curious if this would benefit you at all. So you find a way to where it's disengaging with them. It's not, it doesn't throw their guard up. So that sometimes is just in the language of the approach, where it's like you're contributing to what they're doing, but not questioning yourself.
Yeah,
good
you're
way to
not
kind
trying
of
to
approach
steal somebody from them, but you're also saying, look, at if there's issues that you're having or patients that you're just not able to get, back to 100%, maybe there's other contributions here that might be playing a role that I can help with. Or you can help with, not me.
Mhm.
Yeah.
Good, we left no time for questions. Excellent.
They don't have any. We've explained things
Yeah.
so thoroughly that they understand it completely now.
Should be good.
I should mention, Dave, I have to travel next week.
Okay.
Son's got a tournament out of town, so I won't be around Thursday. And
Mhm.
I'm pretty sure I won't be able to join you on
All right,
the
next
Thursday
Thursday.
following because I'll be in the air on my way out to Chicago.
Okay.
So this
No
will be the last
problem.
you guys see of me, leading up to the actual on-site course.
Good.
So,
All
good
right,
luck
everyone, have a good New Year's.
next couple of